Yes.
Perfect.
Okay, thank you.
Okay, so then I start and continue. I very much enjoyed the lecture given by my colleague Thomas Held. Although we're working in the same institution, it's always intriguing to see a new project ongoing and on how many different levels he's active. Today's topic of my talk will be pediatric. Pediatric is a special indication for particle therapy. It's a very individualized treatment. And as you can guess, it's extremely time consuming because you need to deal with very small children, often requiring sedation. We always treat them in a large interdisciplinary team, not only consisting of typically RTTs and radiation oncologists, but also play therapists, pediatric oncologists, anesthesiologists. And what I will emphasize later on is that most of the treatments are actually conducted within prospective clinical trial. Here, just some pictures from our treatment room. Here, you can see there's an iPad. So we will also use sometimes non-standard positioning equipment, but it's extremely helpful to avoid sedation. So any iPad is better than any sedation, actually. So what are the challenges of pediatric radiation oncology? It's a two-sided sword, the treatment. We've been talking these days several times about the therapeutic window. I just visualized this here with this image of the ancient Roman god Janus with his two faces, because on one hand, there's obviously eradication of the tumor, and on the other hand, there is the priority to spare the healthy tissue. And what is true for adults is especially true for kids. We have an extreme proximity of neighboring organs, just simply due to the small size of the kids. And since their life expectancy is much longer, we need to be aware of the potential long-term side effects we can cause by using radiotherapy. And as I will show you on the next slides, gladly the overall prognosis for children with an oncologic disease has improved over the time. So it's not treatment by any means. Of course, we need to have a long-term local control, but we especially have to be aware of the side effects. So looking at the distribution, I mean, our institution, the Heidelberg Einbeam Therapy Center, is a rather large pediatric oncology center. Last year, we've treated more than 120 kids with radiotherapy. And I just took the age distribution of the last investigation period and divided into protons and ions. By ions, I mean carbon ions. And as we can see, the orange color is basically reserved for adults exceeding an age of 18-year-old. So there are only a very few indications for carbon ion for kids. It's mainly protons. So I could have an easy life and say this is a heavy ion course, and I should talk about carbons for pediatrics. So that's it. There are basically none. But of course, this is not true. So let's have a look. What are the typical indication for particle therapy for children? Some of the entities will be familiar because they also occur in adults, and some other are less familiar because they typically only occur in children. So the standard indications, although extremely rare, are chordoma, low-grade chondrosarcoma, but mainly it is CNS tumors. It's glioma or ependymoma, the whole family of soft tissue sarcoma and bone sarcoma, like head and neck rhabdomyosarcoma, parameningeal rhabdomyosarcoma, Ewing sarcoma, especially in inoperable situation, or paraspinal tumors. We shortly talked also about the craniospinal irradiation in the previous talks. I would emphasize that as well. For some special entities of brain tumors, such as the medulloblastoma, craniospinal irradiation is an absolute standard treatment indication for protons. Looking to carbon ions, this is rather rare. Of course, we can also treat choroma and chondrosarcoma. I will show a couple of slides regarding osteosarcoma and a clinical trial we've conducted, especially for pediatric osteosarcoma using heavy ions, and extremely rare situations are adenoid cystic carcinoma. As my colleague Thomas Held just showed you, this is an absolute standard indication in adults, and it can occur very, very rarely also in children. My apologies, the slide is in German. This is from the German cancer registry. I just wanted to show you that the absolute number of cases is rather low. I mean, oncologic diseases are very frequent amongst elderly, but in children, gladly, this is quite rare. So in Germany, roughly 2,400 kids are newly diagnosed with cancer per year. And yeah, just to a relation, this not nearly comes to the numbers of patients that we treat per year here. And this is the number of children diagnosed with cancer in whole Germany. The distribution, 1/3 is roughly leukemia, 15% lymphoma, and the biggest proportion, at least with an indication for radiotherapy, is definitely CNS tumors, accounting for 1/4 of the first diagnosis. As I said before, the prognosis for overall survival for pediatric cancer has gladly improved very much over the decades. So if we look here at the survival curves, the survival probabilities by decades for brain tumors, we see that coming from the 80s, 90s, 2000 here, 2011 to 2016, we see that with each decade, the overall survival probability has significantly improved. And this is also basically what we can see here. This is the 2-year survival probability for different entities like Hodgkin lymphoma, like Wilms tumor, Ewing sarcoma, osteosarcoma, rhabdomyosarcoma, malignant germ cell tumors. And you can see the clear tendency over the decades that we have a distinct increase of the 2-year survival probability. This is mainly to a special fact I would like to point out here, namely the relative frequency of trial patients. Since children with tumor disease are quite rare, almost every child, at least that's what we try, is enrolled into a prospective clinical trial, or at least a treatment registry. So you have prospective data collection, and you can actually learn. And this is working quite well. We have a very nice reference network. Every child has a reference review for histology, for radiology, for resectability, radiotherapy reference center, and this has certainly impacted the increased overall survival. Of course, as I said, with a good overall survival, we have to shift our focus also to the late side effects. And one very obvious side effect is the risk for secondary malignancies. For brain tumor patients, this number over the last years for the German cancer registry was roughly 8%. Looking into larger numbers, there's the famous childhood cancer survivor study, which was published in 2006, looking at the cumulative incidence of chronic health conditions among more than 10,000 adult survivors of pediatric cancer. And what is really striking is the high percentage of patients suffering not only from any side effects, so the curves in blue here for the total survivors is grade 1 to grade 5 toxicity, and then for leukemia, CNS tumors, Hodgkin lymphoma, neuroblastoma, soft or bone sarcoma. But rather interesting is the red line, which represents the incidence of grade 3 to 5 toxicity. And for all who are not that familiar with the grading, grade 5 toxicity means a lethal toxicity, means that the patient have died from complication. Grade 3 is severe, grade 4 is very severe, and as I said, grade 5 lethal. So we see that the total survivors, over 1/3 or at least 1/4 of the patient has very severe side effects coming from the past treatment after 20 years. Looking into more detail, what are those severe or life-threatening health conditions? We see that the patients can have congestive heart failure, secondary malignancies, extreme impairment of cognitive dysfunction, or coronary artery disease. And we also learned that over 62% of the patients are affected, and 25% of those are vital, and sometimes, depending on, especially on the size of the irradiated volume, they can have more than just one condition. Cause-specific mortality over the course of survival is plotted here. So what are the reasons that those patients die from? Of course, the oncologic disease itself is at highest risk. Once you had cancer, the risk for recurrence is highest. The next is already secondary malignancies. So we need to have strategies to avoid secondary malignancies. And then we see here some cardiac and pulmonary diseases plotted over the time. This is a quite similar plot showing the cumulative mortality. Again, the childhood cancer itself or recurrence is has the highest risk, followed by subsequent neoplasm, followed by circulatory disease or other medical diseases, just here plotted cumulatively. And quite similar to the overall survival, we see that the cumulative mortality has decreased over the decades. So coming here from the 60s to 70s, over the 80s to a more recent decade, we see that the cumulative mortality is decreasing. And this is not only due to better treatment regimens, to less aggressive chemotherapy, but also due improvement from a technical aspect. So with advances, especially also in radiotherapy, we can avoid long-term side effects. And that's the quintessence of particle therapy, I would say. This is rather easy. We have talked several times, also during my previous talks, the physical rationale. Yes, we can perform dose escalation, but and improve thereby the outcome. But especially for kids, those two points are more important. We have to spare the normal tissue as much as possible to reduce late side effects, and we have to limit the volume that is irradiated to an absolute minimum in order to reduce the risk for secondary malignancies. And particularly relevant are those physical advantages of particle beam, especially in very sensitive patients, and when structures, very sensitive structures are involved, and both conditions are true for pediatric cancer. So now let's have a look at the level of evidence. Typically, if this would be a live talk, and then I would see you in the audience, I would say, please raise your hands who is convinced that we have a ton of literature available, randomized control trials, meta-analysis, systematic reviews showing the impact or the benefit of particle therapy for kids. So we see here the pyramid for the level of evidence, and the higher we are, the higher is the level of evidence. But I must disappoint you, we don't have many prospective trials, especially no randomized trials on proton beam compared to photons, because internationally in the community, in the radiotherapy community, it is considered unethical actually to perform those comparisons. This is a rather stunning statement, since those comparisons are always demanded when going to adults. And this is also why I put here a statement from the German Society for Radiation Oncology, just emphasizing that proton beam therapy is not considered being experimental. It is a proven radiation technique, can be performed according to photon standards, and there is typically no special approval by Radiation Safety Board or any other authority needed, and it's widely accepted that proton beam therapy helps to reduce the dose to the normal tissue. So where can we actually spare the most of those? There are some opinions that you should use protons only for very, very small, tiny volumes to avoid a large increase of integral dose. But I would say it's rather the opposite, especially also in very large tumor volumes. You can have a huge impact in sparing the residual healthy tissue. And when it comes to large irradiation fields, we obviously need to talk about medulloblastoma in kids. Medulloblastoma is a brain tumor typically arising here in the posterior fossa and has a very high tendency to spread over the cerebrospinal fluid. The radiation therapy concept is rather complex and aggressive due to the aggressiveness of the disease, and it usually involves the irradiation of the craniospinal axis. And looking here at the target volume delineated in red, you can easily see that basically the whole body is has to be regarded as organ at risk. So this is really for a radiation oncologist and a challenging situation, necessitating the use of special radiation techniques. So what can particles offer here? This is just an exemplary dose distribution for that patient here, the sagittal view. We included the vertebral bodies, although they are not part of the target volume per se, but since this was a small boy with an expected further growth, we had to include the vertebral column to avoid bony asymmetry to further growth. But what I would like to focus is again the potential, the physical advantages, the stopping of the particles, and which is not that pronounced in the head area. Of course, the whole brain needs to be irradiated. But if we go to the neck area and latest in the thoracic region, it becomes really clear. Here on the level of the heart, we see that we only have a very, very tiny rim receiving any dose, while the biggest proportion is spared completely. And you can easily imagine if we only treat the spinal canal, then our dose fall-off would lie here within the vertebral body, and then you basically have no dose at all received by the heart. So this is the DVH to that, and this is a very pragmatic comparison of a proton plan and a IMRT. In this case, it was helical IMRT, where we see that in the neck region, in the thoracic region, but also in the abdominal region, we have the low and intermediate dose bath, which we actually would like to avoid, because we said the risk for secondary malignancies is very high in kids because they have this long life expectancy. And then this is definitely something you would like to spare and avoid, because this comes close to a whole body irradiation if you want so. The principle of craniospinal irradiation is working. So this is nothing we just show in silico, and the dose distribution looks nice in the treatment planning system. But this is also what we see in the clinical routine here in a boy that was a little bit older, 16-year-olds, where we restricted our irradiation here to the spinal canal. So we see that the dose follows lies within the vertebral body. And then if we look at the follow-up MRI performed 6 months later, we see those fatty changes in the vertebral body. And if you look very, very closely, you see the high accuracy of our treatment. So it proves the entire chain, including patient positioning and then beam application, because here even the slightest deviation of the 30% isodose is projected in those fatty changes in the vertebral body. And here again, we have the small outline of the 30% isodose, which we can see here. We see that the anterior part of S1 was spared, and we also can see that here. So we have a very, very precise mean of treating the patients. And especially in the latter situation, you see that there is no dose absorbed in the abdominal region. There's no dose absorbed by the large vessels in the abdominal and thoracic region, and a significant proportion of the bone marrow in the vertebral column is also spared. And the colleagues from Brown et al., they actually could show that sparing not only the bone marrow, but also the rest of the body here with the aorta abdominalis, etc., leads to reduced acute toxicity with regards to hematology. And if you remember, this can have positive impact. I showed you on the talk before the outcome on the overall survival benefit for palliative irradiation, craniospinal irradiation, leading to an overall survival benefit when performed with protons. But let's focus again on the kids. I will come to secondary malignancies in a second, but when we talk about kids and brain tumors, which, as I said, is the most frequent indication for radiotherapy in children, then of course the neurocognitive outcome is of importance. And radiotherapy in general with protons has the goal to reduce the burden of neurocognitive impairment. Some of you might wonder, where is the potential to spare neurocognition if you compare those two slides? Because basically in both scenarios, you treat the whole brain, and regardless whether this is done with protons or with photons, the brain receives the same amount of dose. I agree, this is correct, but this is not the full story, because this is only the primary plan. So the elective irradiation, if you want so, of the CSF, but there's a second part of treatment focusing on the tumor bed in the posterior fossa, applying a high dose of up to 54 gray, and there obviously makes a difference, as we've seen by numerous dose comparison studies, that if you perform irradiation of the brain with protons instead of photons, you reduce the absorbed dose to the healthy brain, both supratentorally as well as infratemporal. And this actually leads to a better outcome also in neurocognition. A colleague of mine had a look at that, at the neurocognitive outcome, comparing surgical cohort, photon cohort, proton cohort. The colleagues around Pulsifer could show that the quality of life and the impairment for neurocognition is better. And of course, there was this very, very optimistically title of superior intellectual outcome after proton. Of course, they haven't improved, but the negative impact was less. So with the means of proton irradiation for pediatric patients, you can actually spare neurocognitive function and the negative impact are diminished. When talking about protons or ion beam therapy, sooner or later, someone will come and say, yeah, but this is not cost effectiveness. The treatment is extremely expensive. This is right to a certain degree. The treatment itself might be slightly more expensive here. One of the rare cost-effective analysis coming from Lundquist, he stated that the proton treatment is roughly charged with 10,000 euro, the conventional radiotherapy with 4,000 euro. Of course, this definitely depends on your situation, on your institution, on the country, on the legal aspects with the insurance companies. But in his cost-effective analysis, the authors came to the conclusion that although the treatment itself might be a little bit more expensive, the cost that comes from the adverse events could be reduced significantly. So taking it all into account, they said that proton therapy was not only associated with less cost for overall, but it was also coming with 0.7 additional life years and 0.6 additional QALYs per patient, which is a measurement for quality of life for those patients. So not only it's reduced the side effects, but it's also cost effective. So it's no wonder that proton beam therapy basically has become a standard in treating pediatric brain tumors. Whenever there is the possibility to evaluate access to proton beam therapy, it should be evaluated. Of course, there are frequent constellations also where the factor time is important, and sometimes the patients actually benefit more from a timely initiation of treatment rather than the treatment technique, especially for very aggressive tumors like medulloblastoma. We know that there's a time interval we need to stick to, which is typically day 40 after surgery, where we would like to start the treatment. But otherwise, I just depicted a few examples like craniospinal irradiation, like whole ventricular irradiation, focal irradiation, tumor bed irradiation. This is basically all become standard of care for pediatric brain tumor patients. But it's not only about the brain, it's also for non-CNS tumors. The most frequent indication after brain tumors is the family of sarcoma, bone and soft tissue sarcoma, namely osteosarcoma, rhabdomyosarcoma, Ewing sarcoma, and a little bit less frequent also lymphoma, which I would like to focus on today a little bit, neuroblastoma or retinoblastoma. Coming back to the secondary malignancy risk, this is a really important and major issue. And this publication in Cancer from 2020 looked at a significant proportion of patients and had divided those cohorts into three cohorts: 3D conformal radiotherapy, IRMT, and proton irradiation. And in the matched multivariable analysis, proton beam therapy led to less secondary malignancies compared to IRMT and photons in the median follow-up of 5 years. So what we postulate that the theoretical advantages there could also be shown in a real world collective. And just as one example why proton beam therapy can be so effective in avoiding secondary malignancies, I would like to show this case of retinoblastoma, a child with a diagnosis of bilateral retinoblastoma in 2008, was decided to go for enucleation of the left eye and irradiation of the right eye. And if we go down here, again, you might notice I haven't shown the depth dose profile of particles. I tried not to show it this time because I've showed it so many times before, and you've seen it from my colleagues in the other talks as well. But still, here's a permutation of it. We see the dose distribution of photons in it. Even if I treat the right side and perform my prescription. So I have the prescription dose here to the target volume. I still have a significant amount of radiation dose, 80–70% of the prescription dose on the contralateral side. And unfortunately, 7 years later, this was the follow-up image. So the patient was treated on the right side with photons, and on the left side, which was enucleated, undifferentiated sarcoma was diagnosed. And if this treatment would have been performed with protons, the dose distribution would have looked something like that, and the dose would basically stop in the midline, and the contralateral side wouldn't have received any amount of radiation dose. So I think that's quite convincing why you can reduce the risk for secondary malignancies. And this is not only true in one case, but also in larger cohorts. Sethi et al. Looked at a cohort of 68 patients with a median follow-up of 7 years for protons and 13 years for photons, comparing the risk and the cumulative incidence of secondary malignancies in field, and we clearly see that there's a distinct difference and a significantly increased cumulative incidence of secondary malignancies coming from photons. And the radiation dose regarded to be significantly increasing the risk for secondary malignancies was regarded as low as 5 gray. And secondary malignancies is really an important issue when treating children. Again, another publication from the Childhood Cancer Survivor Study coming from Moskowitz. The authors investigated 1,230 female childhood cancer survivors treated with chest irradiation and compared the impact of whole lung irradiation versus the so-called mantle field irradiation. And they could see that the larger volume, like whole lung or mantle field, was associated with an increased risk for secondary malignancies in the cohort. And what is really striking is the high cumulative incidence of breast cancers by the age of 50 years, which was as high as 30%. And this is also significantly impacting the mortality of those patients. So to avoid long-term side effects coming from mediastinal irradiation whenever the heart, the lung, and the breast tissue is involved is extremely important. And there are also 2 other publications from Conway and from Scharpfeld, one 700 patients, one 3,900 patients, after 20 or 40 years after surviving a childhood Hodgkin lymphoma. They could see that mantle field irradiation is associated with increased risk for breast cancer compared to small volumes. So again, the size of the tumor volume or the irradiated volume impacts also the risk for secondary malignancies. And again, the striking high numbers, cumulative incidence for secondary cancers was 49% in this cohort after 40 years. And the colleagues from Hodgins et al., I borrowed this from the Hodgkin study group here, this slide. They tried to make individualized estimates for secondary cancers using contemporary radiotherapy techniques and prescription doses. And we can see that the cumulative incidence for breast cancer, as modeled here, goes down by adapting the size of the irradiated field coming from the mantle field to involved field radiotherapy with 35 gray and involved field radiotherapy with 20 gray. And this nicely shows the impact of size and prescription dose. So there's a good rationale to really decrease the dose as much as possible to the healthy tissue and to limit your target volume as best as possible. Van Nijmegen and Lipschultz also are very famous works for cardiovascular toxicity, because they could see that there in over 2,000 patients that there's a 2.5-fold increased risk for coronary heart disease for patients receiving a mean heart dose of 20 gray. And they could see that there's a dose-response relationship, that with each excessive gray mean dose, you have an increase of the relative risk by 7.4%, and also an increased risk of cardiac mortality by 60% per gray. So really a very, very strong rationale to limit the dose to the heart, to the breast, to the lungs as much as possible. Typically, this is then the point where I also insist on the importance of smoking cessation, but this is a topic for another day. So let's have a look at mediastinal lymphoma. In this case, diffuse large cell B-cell lymphoma of a 26-year-old female patient. Had a stadium 2A initially with a bulky disease and indication for consolidation radiotherapy, 36 gray in 18 fractions treated with photons, and down here the correlating treatment plan with protons. And we can see that the demean of the heart is reduced by 50%. The demean of the breast on the right side and the breast of the left side could also be significantly decreased. And given the dose-response relationships we've seen before, I think the rationale to use particle therapy for those patients is also rather convincing. To look into this comparative planning in a larger cohort, we can see that using PPA techniques compared to IRMT to protons, we can lower the median heart dose actually from 30 to 9 to 0 degree, because it's 0 gray, because there's only a very small rim receiving dose, and the biggest proportion of the heart doesn't receive any dose, and the mean heart dose is reduced from 22 to 6 gray. Of course, these long-term side effects, they need time to be evaluated and to be proven, but given the extremely good evidence from historic cohorts, it is definitely expected that this kind of dose reduction translates into beneficial clinical effect. So much for the rationale for protons. Now, finally, I come to carbon ions, which are you eagerly waiting for, I hope. Again, we talked about the biological rationale for heavy ion or light ions or ions other than protons before. So this is a repetition. It's not only about the physical advantages, of course, also, but especially about the biological properties. As you already know, they have an increased relative biological effectiveness, and the high linear energy transfer of those radiation modalities is more efficient in killing hypoxic tumor cells. They have the possibility to overcome typical mechanisms of radioresistance. For example, they are independent of the cell cycle the tumor cell is, and this becomes particularly relevant for large inoperable diseases, for radioresistant tumors, or as we have talked before in the re-irradiation session, also for previously heavily pretreated patients, for example, with conventional radiotherapy. A very good example, therefore, is osteosarcoma. If we look at this work from Ziernik, because osteosarcoma is also a common indication in the pediatric cohort, although surgery plays an extremely important role, there are unfortunately situations where the disease is inoperable. And if we look at historic outcome, we see here on the local control probability curve that we got stuck with conventional radiotherapy at a certain point. We have here some results achieving better outcomes. But with conventional radiotherapy, we actually can't achieve that. And this is simply due to critical organs at risk, as the brainstem, the optic system, and the spinal cord, whose tolerance doses are here at 50, 54, and 60 gray. And with conventional radiotherapy, I can't overcome the radioresistance and treat with 70 or 80 gray while respecting the tolerance dose. So if I want to come in these spheres and achieve a higher local control, this is where ion beam therapy becomes important. And here I brought some typical examples coming from a prospective trial we conducted, the so-called OSCAR trial. In the upper row, we have a craniofacial osteosarcoma case. Here in the right maxillary sinus, the PET from a previous RT showing the metabolic activity, because typically the bony structure that has been built by the osteosarcoma doesn't disappear. So there's no good means of evaluating the tumor after radiotherapy because the dimensions are basically the same. Here we see our carbon ion treatment plan and the PET after radiotherapy, where we see a significant decrease of metabolic activity. And what is striking also for inoperable pelvic disease, this is at least a silver lining at the horizon, because those cases are otherwise have an extremely poor prognosis. We see here this large contrast enhancing mass in the pelvis, which is obviously inoperable and would lead to mutilating surgery, but it is just lying next to the bowel. We would like to administer 80 gray or more. Here we would like to limit the bowel to 50 gray, so this is extremely difficult. But with particle therapy, we can overcome this problem, treat the tumor with a high dose, and achieve at least a certain metabolic response. This is actually coming from a 16-year-old girl that we treated now 9 years ago, I think. And this was the first PET. I just got news from Austria, actually. She was referred to us from Vienna, that she is not only still alive, but she has also still local control. And what was extremely nice news is that she has become the mother of a healthy young boy. So it was just this year that she gave natural birth to a healthy boy, which is really, really astonishing given her oncologic history. And sometimes these are the patient stories you need to cheer you up and to push things forwards. And this is really a very, very nice story. And then comparing the results from the OSCAR trials to others, it's optimistic and favorable results. We learned, as I guess my colleague Katharina Seidensaal already showed you in the osteosarcoma talk, that head and neck osteosarcoma do even better compared to those unfavorable huge pelvic osteosarcoma, but still it is a right step into the right direction. And with that, I would like to summarize. There's no question that proton beam therapy is significantly superior, especially in sparing organs at risk, and therefore also in the reduction of long-term sequelae. And this is not only a theoretical advantage, but especially in the pediatric cohort, we see those results now. There is evidence that we have reduced hematotoxicity, that we have reduced secondary malignancies, that we have reduced neurocognitive impairment. And that is why especially suitable candidates for protons are very young patients with a long life expectancy. And as we have learned from thoracic irradiation, also female patients, particularly if elevated risk for breast cancer is there. And if we have a target volume that is limited in close proximity to the heart, or in patients who have a large treatment volume, such as the CSI. And with that, I would like to conclude and make a certain advertisement. As I said, the treatment of children is very, very individually, and I very frequently get visits from different superheroes. Sometimes I learn also new name from superheroes. So I wasn't aware of Venom before. Sometimes the kids have a really nice fantasy and do this astronaut. And then there are typical Batmans, Spider-Mans, Iron Mans, etc. And whoever is interested, unfortunately, it's currently only available in German, but we currently recorded together with Dr. Wimmer, Parents and Children's Radiotherapy Video Guide. Here is the QR code. Those videos are available on YouTube, and the families can have a look and they learn about FAQ of radiotherapy, about the general procedure of radiotherapy, what happens, and then some explanation for kids. And with that, I would like to end. Thank you very much.
Thank you so much, Dr. Harrabi, for your wonderful lecture. We have a number of questions. We have some time, so we can go through them all. So first question, in pediatric radiation oncology, are there joint international dose-constrained guidelines like Quantec? I've heard about the Pentec initiative, but it's still in report preparation. Or we just always go for ALARA principle and reduce OAR dose as much as possible?
Well, thanks for the question. That's a very important one because you know, there's a very, it's common knowledge that children are not small adults. So is it legitimate to use the same dose constraints? A very relevant question. Partly yes. Partly we use actually the same dose constraints, but since the tissue is still developing, there is also an age adaptation. And although there are only some recommendations and guidelines published for dose constraints, we aim to homogenize that. And as I said, there's a really nice reference network amongst also radiation oncologists. And by that, you should get uniformed recommendations how to treat the patients in terms of target volume, dose prescription, and also organ at-risk constraints depending on the trial the patient is enrolled to. But the ALARA principle is a very good one. Just push your border. It's not like you have a constraint, and if you meet the constraint, you're fine. Always push to the limit and reduce the dose as much as possible.
Thank you so much for your detailed reply. Next question, how long do you follow the kids treated with protons or ions? For life?
For life would be desirable because many of those side effects occur only decades later. But obviously this is unfortunately not possible. We're about to install a follow-up unit for long-term survivors, but at least we try to follow them for a period of 10 years.
Okay. Next question. Did the second cancer risk study you showed, protons versus photon IMRT, take into account the risk of energetic neutrons created by protons, which is 0 for IMRT?
Very, very good question. Well, when talking about secondary neutrons for protons, you must say that protons are not protons. It makes a huge difference whether you have a passive beam application or you have an active beam application, because the order of magnitude of neutrons that are produced can differ significantly. I think I haven't shown that slide. There was also one publication from the colleagues with secondary malignancies not aiming to show superiority in terms of producing less secondary malignancies, but the other way around, exactly with that point in mind, not to produce more secondary cancers. And from the clinical observance, the answer is clear: no. Protons cause less secondary side effects, and also the issue of neutrons actually is somewhat overestimated. Also with carbon ions, where we have fragmentation, where we produce secondary neutrons, but due to the relative biological effectiveness, the absolute amount of neutrons produced are rather comparable to protons. So even with carbon ions, there's no fear anymore of increased secondary malignancy risk due to neutrons.
Thank you, Dr. Harrabi. Fourth question, for medulloblastoma, when we irradiate the tumor, we irradiate the spine with it, even if there is no spread of the tumor in it. I mean, the tumor may be in the brain and has not yet reached the spine. Do we use the same area as the previous one that will be exposed to radiation?
The answer is yes. Of course, it's an important question, and it's always a point of discussion with the parents. Why do I need to treat the whole craniospinal area if the tumor is only located in the posterior fossa and hasn't spread? There are no malignant cells in the CSF. There's no macroscopic deposits visible on the spinal MRI. But still, this approach has been followed for a certain period, but the results were basically a catastrophe. So extreme high recurrence rate, and then this path was left. Currently, there's an approach of risk-adapted craniospinal irradiation. Depending on the M status, you can decrease, and the molecular subentity of the medulloblastoma, you can decrease the dose to the spinal irradiation to 18 or 23.4 gray, and in the high-risk situation, you would rather give 35.2 or 36 gray. But besides very, very rare constellation, the craniospinal irradiation is basically always part of the treatment of kids with medulloblastoma.
Thank you for your answer. Next question. In the future, what potential and possibilities do you foresee for helium-ion therapy in treatment of pediatric cancers? Could it give significant improvements over proton therapy?
Oh, thanks a lot. I really love that question. As you might have noticed during this talk, but during my previous talk, I always put in some advertisement for helium, because as you know, our institution is currently pushing forward the introduction of helium ion. And I've just given a very short rationale for helium. Why should there be an improvement over protons? Well, the most relevant question might be the small word significant improvement. From a pure dosimetric point of view, I've showed you the comparative treatment planning between protons and helium ions. And since helium ions are slightly larger, they have less lateral scattering, so we have a shorter or a smaller penumbra in the patient. And depending on the tumor localization, this can actually make the difference. We just finished a medical thesis where Ricarda Wickert looked at the potential of improvement for patients with pediatric ependymoma in the posterior fossa, because there you have the inner ear, you have the pituitary, and you have the brainstem. And you have the situation that depending on macroscopic residual disease, you need a dose escalation of more than 60 gray. And this is really where even helium with those slight physical differences can make a difference and leads to better tumor coverage, and especially also better organ at risk sparing compared to protons. So if you want so, you can regard heliums as a proton 2.0. Rather an evolution than a revolution.
Next question, thank you. How do you reconcile the stray doses, out of field doses, due to secondary radiations like neutrons, which may extend to farther distances to further distance to their possible impact to introducing secondary cancer in children? Do to PS take their corresponding absorbed doses into account with better accuracy too?
To my knowledge, so I'm not an expert on treatment planning systems, but to my knowledge, this is not implemented yet. It's a rather simplistic view on the dose distribution. So we could still refine that in terms of modeling for risk of side effects. But again, given the clinical evidence, the issue of neutron dose, especially in active scanned proton beam therapy, might be overestimated.
Okay, next question. Are there clinical research gaps that still exist in proton heavy ion therapy for pediatric patients, particularly in the workflow and treatment planning?
I'm not quite sure if I understand that question correctly. Well, of course, even if the field is well investigated, we're still standing in the beginning, and there are many projects ongoing to further improve the outcome regarding the workflow with play therapists, with these video guides in order to see whether we can prevent sedation for pediatrics, and also with regard of indications. With carbon ions, we're actually just starting. I just showed the indication for osteosarcoma, where we had a prospective trial, but osteosarcoma is not the only potential indication for pediatric carbon ion irradiation. But there are rather more and more indications that are opening up. For example, soft tissue sarcoma, there are sometimes fusion-driven subtypes which have a very unfavorable prognosis. So there's still a lot of research to do.
Okay, it seems like this is the last question. What is the reference for dose constraints for pediatric patients undergoing